Esophageal varices are extremely dilated submucosal veins in the lower third of the esophagus. They are most often a consequence of portal hypertension, commonly due to cirrhosis. People with esophageal varices have a strong tendency to develop severe bleeding which left untreated can be fatal. Alcoholic liver disease occurs when a person consumes 1 beer, 4 ounces of wine, or 1 ounce of 80% spirits. All of these contain 12 grams of alcohol. Threshold for developing alcoholic liver disease in men is an intake of 60 to 80 grams/d of alcohol for 10 years. This table lists the causes of liver cirrhosis such as alcoholism, chronic viral hepatitis, biliary cirrhosis, cardiac cirrhosis among others. Manifestations of liver cirrhosis include neurologic, gastrointestinal, reproductive, cardiovascular, hematologic, and metabolic. Hematologic manifestations of liver cirrhosis include anemia, thrombocytopenia, and splenomegaly. Cardiovascular manifestations include fluid retention, peripheral edema and ascites. Esophageal varices may present as upper gastrointestinal bleeding. Differential diagnoses for upper gastrointestinal bleeding include gastric ulcer, duodenal ulcer, neoplasm and hemorrhagic gastritis. In patients with hepatitis C infection, 80% develop chronicity and about 20% have liver cirrhosis in 20-30 years. In patients with hepatitis B infection, 5% develop chronicity and 20% develop liver cirrhosis in 5-10 years. The development of esophageal varices begins with extremely dilated submucosal veins in the lower third of the esophagus and portal hypertension. Blood flow through the hepatic portal system is redirected from the liver into areas with lower venous pressures. This leads to development of collateral circulation. Esophageal varices are portosystemic collaterals. There are vascular channels that link the portal venous and the systemic venous circulation. Under a normal condition, the portosystemic collaterals are collapsed. While in portal hypertension, there is engorgement of blood vessels which divert blood to the portal circulation. There are important sites of these collaterals. At lower end of esophagus, around umbilicus, lower rectum and anal canal, at back of colon and retroperitoneum. Varices rupture if the wall tension becomes too great. The likelihood that a varix will rupture and bleed increase with increasing size or diameter of the varix and with increasing variceal pressure. Grading system for esophageal varices as proposed by the Japanese Research Society for Portal Hypertension show a grade 0 if with no evidence of varices on endoscopy. Grade 1 if varices run straight. Grade 2 if varices showed beaded appearance and grade 3 when varices run in oblique course and are tortuous with tumor-like appearance. This picture is an example of grade 0 varix. This picture is of that a 61-year-old woman with cirrhosis but no esophageal varices. This picture shows an endoscopic image with grade 1 esophageal varices presenting with cherry red spots. Grade 2 esophageal varices have bead-like appearance. This picture showed a grade 2 esophageal varices in lower esophageal segment in a 58-year-old man with liver cirrhosis and concomitant gastric submucosal varices and hepatocellular cancer. Note the arrows. This picture is an example of grade 3 tortuous and tumor-like esophageal varices. This is an image of a grade 3 esophageal varices in the lower esophagus of a 60-year-old man with cirrhosis. In patients diagnosed with cirrhosis, they are to undergo upper GI endoscopy to check if there are esophageal varices. If no varices are found, repeat endoscopy is done in 3-4 years. If there are grade 1 varices found, a repeat endoscopy is done after 1 year. If grade 2 or 3 varices are found, patient is given propranolol at 80 to 160 mg per day. If this is not tolerated, variceal band ligation is done. Treatment of esophageal varices may be sclerotherapy or variceal band ligation. In sclerotherapy, a 1-3 sclerosant such as ethanolamine is injected into the varices. This is to occlude the venous channels. Sclerotherapy requires multiple sessions like twice weekly. Bleeding is controlled in 80 to 95% of the time and about 50% rub a lead. Endoscopic sclerotherapy may either be intravariceal where the sclerosant is injected directly into the varices, or it may paravaricial where sclerosant is injected adjacent or beside the varices. Another treatment option for esophageal varices is endoscopic banding. Just like sclerotherapy, it is meant to occlude the venous channels. But compared to sclerotherapy, it has fewer sessions. Endoscopic banding is the endoscopic treatment of choice for esophageal varices.